So good afternoon, everyone. We are just waiting for a few moments as all of our attendees log on. We will start presently. Thank you. Good afternoon, everyone. You are all very welcome this afternoon to our Sláintecare webinar. I'm Gráinne Healy, Chair of the Sláintecare Citizen and Staff Engagement Forum, and I'm really delighted you've joined us for today's webinar, the 13th Sláintecare Integration Fund webinar, which is part of our Learning Network event series. We are taking questions during the broadcast, so if you're asking a question or making a comment, please do indicate who the question is for, and we will make sure to get the answers for you. The chat button for Q&A is at the bottom of your screen, and if you type in a question, it will come straight into us. We are very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is about providing right care in the right place at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Sláintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adapted work practices and created improved pathways while responding to COVID-19. Our theme this afternoon is on citizen empowerment for optimising patient quality of life. Many Sláintecare Integration Fund projects have a focus on prevention and on empowering people and communities to be more engaged in our own health and well-being. The innovation and best practice that all these projects represent will be of great value to the work underway in every county to implement Healthy Ireland as a key part of the Sláintecare vision. So with that in mind, yesterday, Minister for Health Stephen Donnelly, TD, and the Minister for Public Health, Wellbeing and the National Drug Strategy, Frank Fein, TD, launched a new initiative to support increased health and wellbeing services to 19 communities in Ireland. Sláintecare Healthy Communities is a new cross-government initiative to deliver increased health and wellbeing services to 19 community areas right across Ireland. The goal of the Sláintecare Healthy Communities programme is to improve the long-term health and well-being of the people living in these communities. These initiatives will be delivered in partnership with a number of groups working together to provide a range of dedicated services to build lasting improvements in both health and well-being. We want to share with you a little video from the launch.
delighted to be here in Darndale today to be launching the Sláintecare Healthy Communities initiative. It's a €13 million annual programme. It's very exciting, and what it's going to be doing is supporting work between the Department of Health, the HSE, local providers to roll out additional supports in these 19 communities to help address persistent health inequalities.
Local authorities are very happy to partner with healthy communities. It gives us an opportunity to work with state agencies and with voluntary and community groups to ensure that the health and well-being needs of our communities are supported. Healthy Communities is focused on broader determinants of non-medical determinants of health, and that's areas, it touches on areas where local authorities have a key role and we can make a huge contribution to achieving the objectives of healthy communities working with various partners.
It's great to be launching this initiative. It'll tackle the health and well-being in 19 communities around the country. Some aspects, so you have social prescribing, you have smoking cessation, and you have walking and opening up of various walks around the country. So again, we're very excited, and we're very thankful for all the agencies and all the various stakeholders are buying into this very it's successful and very exciting initiative.
I hope it is the start of a new way of looking at healthcare and healthcare provision in our country to make sure that boys and girls growing up, that they all have the same opportunities in life in terms of physical health, mental health, emotional well-being. It shouldn't matter where you're from, it shouldn't matter what gender you are, it shouldn't matter how much money your parents have. Everyone has got to get the same chance in life, and at its core, that's what this initiative that we're launching here today is all about.
Great, so we're delighted to see this programme being launched, which will address local needs with local partnerships, all promoting health and well-being to reach into communities right across Ireland where those interventions are most needed. Engagement with and empowerment of citizens and co-designing the kind of health service we need for our growing population is, as you know, a cornerstone of the development and the strengthening of the health service. We have 3 innovative and I think exciting projects to showcase for you this afternoon, focusing on empowerment and prevention. They include an initiative on skin cancer prevention, an update on the Living Well series of projects improving health outcomes for those living with chronic disease, and a really interesting project on rehabilitative palliative care, helping patients cope with changes associated with deteriorating health. So let's go to the first of our 3 project presentations. Turning now to skin cancer prevention planning and an initiative being delivered by the HSE and the National Cancer Control Programme. Cancer prevention is a cornerstone of the National Cancer Strategy, offering a cost-effective long-term approach for cancer control. The strategy includes a recommendation to develop a skin cancer prevention plan. This is the first national initiative of its kind, a landmark commitment to skin cancer prevention, aligning with the Healthy Ireland vision. Over 11,000 cases of skin cancer are diagnosed each year in Ireland, and this number is projected to nearly triple by 2051. The rising incidence will increase demand on acute healthcare diagnostics and treatment services. However, skin cancer, as we know, is one of the most preventable cancers. The primary aim of the Skin Cancer Prevention Plan is to stem the rapid rise in cases of skin cancer in Ireland. This is part of the longer-term plan to establish skin cancer prevention controls. Specific actions are being designed to reach children, outdoor workers, including agricultural and construction workers, as well as those who participate in outdoor activities, through relevant policymakers and networks, as well as the media. And these will include, we understand, awareness raising through social media, engagement with public events to promote skin protection behaviours, incorporating skin protection messages into existing educational programmes, and creating supports for organisations involved in this work. I am delighted to be joined this afternoon by Maria McHenry, the HSE National Cancer Control Programme Cancer Prevention Officer. Maria, thank you so much for joining us this afternoon.
Thanks, Grania. I'm delighted to be here.
So Maria, will you tell us a little bit about the National Plan for Prevention of Skin Cancer and your work there? Who's on the team and what did you set out to achieve as part of this initiative?
Yeah, so I suppose to give you some background information on the National Skin Cancer Prevention Plan. So it was implemented, I suppose, with the rising incidence. So as you said, the number of people being diagnosed with skin cancer is increasing. It's actually over 13,000 cases this year. It's increasing year on year, which is worrying. But I suppose the important thing to note is that skin cancer could be prevented by protecting our skin from UV radiation from the sun. So a lot of the work that we're doing is we're targeting high-risk groups that include children, young people, outdoor workers, those that pursue outdoor leisure activities, and sunbed users. So I suppose I work with a wide range of organisations, groups. So my role is to coordinate the implementation of the National Skin Cancer Prevention Plan, to oversee the implementation in a timely manner. So I work with a wide range of people, including governmental departments, statutory bodies, healthcare professionals, non-governmental organisations, and also patient representatives as well. So there's a number of key action areas within the plan. So I work across all of them with all the key people. So I suppose the overall aim of the plan is to reduce the rising incidence of skin cancer. But as well as that, I suppose we want to raise awareness of how people can protect their skin, also encourage people to change their behaviours. So I know that'll take time to do, but we're, I suppose, raising awareness of things you can do to protect your skin, and also monitor and evaluate the plan's effectiveness to make sure that we are reaching those goals. We are, I suppose, increasing awareness of skin cancer. And it's also important to note that we're doing that across education. So we're working with schools. We're also doing that with our annual media campaign, the SunSmart campaign, policy change and environmental change. So it's working across a wide range of areas and building blocks towards, I suppose, that overall aim of reducing the rising incidence of skin cancer here in Ireland.
And Maria, talk a little bit about the priority groups that you've mentioned, particular groups you're trying to reach. Why target them in particular?
Yeah, so I suppose one of the at-risk groups are children, young people. So we know that children are particularly vulnerable to UV exposure from the sun. So their skin is very sensitive. And we also know research has shown that if children are sunburned, severely sunburned 3 or more times before the age of 20, the risk of developing skin cancer later in life increases massively.
Wow.
So I suppose we work with early learning centres, with school age settings. So we know that if we reach them at a young age and we introduce behaviour change and things they can do to protect their skin, they're more likely to adopt that later in life. So some of the work we've done with them, I suppose we have a SunSmart education programme, which we've trialled in the west of Ireland in 44 schools. So we're hoping to push that out as part of the SPHE curriculum next year into more schools. We've also done a consultation with kids. So I suppose we want to understand from them where they get their health information, what they want it to look like. Do they want it to be fun, creative? Who are their sources of information? So do they talk to their teachers? Is it their parents? So we're in the middle of doing that consultation at the moment, which is going to help inform us of future resources and programs, initiatives that we run. When it comes to outdoor workers, then they're another high risk group that we're targeting. So we know that they're outdoors quite a lot. So their level of exposure to UV is a lot higher than, say, someone who would work indoors. So we're working with the Health and Safety Authority. We work with the farming, the fisheries, postal service, construction industries, and a wide range of different stakeholders. So for us, it's engaging with the workplaces to ensure that they have the policies in place to protect the workers. We're also developing a risk assessment tool so they can adapt and figure out when it is really high risk for the workers outdoors, introducing different shift patterns in work, shade provision. So we've done a number of webinars and education events, and we have seen a massive increase in engagement levels with those outdoor workers, which is really, really great to see. I suppose the third group that we're I suppose reaching out to is those that pursue outdoor leisure activities. So that could be sport or tourism. So we know that exposure causing sunburn is the most damaging, but also long-term non-burning exposure can also significantly increase your risk of skin cancer. So if people are outdoors a lot, not protecting their skin, they would be at higher risk. So we're working with Sport Ireland. So we've developed a framework and a sample policy on, I suppose, protecting your skin and what they can do with the outdoor leisure organisations. We've also worked with Let's Go Summer Camp. So they have, we've provided long sleeve tops for the kids and also games for the kids to educate them in a fun way of how they can protect their skin. And then I suppose the last group, the fourth group that we're targeting is Sunbed users. So we know that people who use sunbeds before the age of 35, they increase their risk of developing skin cancer by 75%. So that's a massive, massive amount. And we do know that, I suppose, sunbeds are cancer causing. They are group 1 carcinogens. So we've done a lot of work with, I suppose, the risk groups who would use sunbeds. So we've worked directly with Pave Point. So I suppose to engage with the travelling community on the risk of using sunbeds. So we've done an education event with them and provided leaflets to educate them. We also have ongoing linkage with the environmental health officers as part of the HSE Sunbed office. So that's, I suppose, looking at the number of registered sunbed users here in Ireland, the number of infringements, and making sure that people are, I suppose, following the law in place with regards to sunbed use. So I suppose that's just a top level overview of some examples of the work we're doing. There's a lot of work ongoing. So that's just some of the areas.
And it's interesting that with the different groups you are looking at, it's not one size fits all. You really do have a variety of strategies to target them in particular. And I know that the summer camp work has been going on. My own grandson was able to tell us exactly how often he needed to reapply his sun protection factor last summer. I suppose, you know, the issue of different groups, different strategies, the challenges that you've encountered. I mean, there's still a lot of myths going around out there. You hear people saying, oh, Irish sun, yeah, that wouldn't give you cancer. It's only if you're in Spain. Those kind of myths, are they a challenge to try to overcome some of that misinformation?
Oh, definitely. And that's, I suppose, why we're trying to engage with a wide range of groups. So I suppose we have those high risk groups, but we do also target population wide. So we have our annual SunSmart campaign, and that runs from April to September every year. So we try to, I suppose, do some myth busting with that. And I suppose we have a radio campaign that we ran this year. And we talk about, even when it's cloudy here in Ireland, you still need to protect your skin. So we've tried to, I suppose, highlight that to people, and we've got really good feedback on that campaign to date, and it's grown year on year. But yeah, definitely there are some challenges that we face. I know with COVID-19, that also impacted some of the action areas we had as well. So I suppose we had planned to do a lot of face-to-face programs and initiatives, but with social distancing and COVID, we've had to adapt our methodology. So as I said, with the consultation with kids, we wanted to do that face-to-face, but we've done it online and it has worked really, really well. So I suppose just making those changes has helped. And the at-risk groups then as well would be like the travelling community, engaging with Pave Point to understand the best way to work with them. So we did a train the trainer type thing. So we had their primary healthcare team, we educated them and we did a training session with them, and then they went out.
They rolled it out.
And they ran out and they went out and talked one-on-one to people. So that was really interesting for us to learn the different ways to engage with different groups.
Very good. And in terms of monitoring the success or the efficacy of your efforts, have you any preliminary sense of what your outcomes are? What successes are you having?
Yeah, so I suppose we know that behaviour change takes a long period of time to do, but with our SunSmart campaign this year, because we introduced radio as part of the campaign and we grew all the different aspects with social and print, we wanted to have a look at, I suppose, how we can engage people and what the changes are. So we did a pre and post campaign evaluation, and I suppose some of the initial findings that we have found is that people are more likely to use sunscreen, avoid the midday sun. So we know if you're outside between 11 a.m. to 3 p.m, that's when the UV rays are at their strongest. So people are more likely to avoid the midday sun, we have found post-campaign. So that's really great to see. Again, we're not going to see people, all of the different behaviour changes all at once. So we will have more information on that with regards to the report. But we have found overall really good engagement with organisations as well, with outdoor workers, outdoor leisure. It definitely took time to build the relationships, but we've people coming to us all the time now wanting to run their own initiatives in-house or their own programs, looking for ideas or resources. So it's great to get people to come to us and looking for that support, which is brilliant.
Very good. And Maria, I saw in an article that you featured in the Irish Examiner in June that you yourself, like myself, always apply SPF 50 every day. If you had to give our listeners one piece of advice in how each of us might ensure we avoid skin cancer, what would that be?
Yeah, so I suppose it has to come back to the SunSmart 5S's. I suppose that's key as part of our campaign. So I tried to make it as easy as possible for people to remember. So the first one is slip. So slip on clothing that covers your skin. Slop, so slop on sunscreen. So for adults, we would say factor 30. For children, factor 50. Slap on a wide brimmed hat. Seek shade, as I said, between 11 a.m. to 3 p.m. and then slide on sunglasses. So there are 5 different things people can do. So if maybe you're not doing one of them, you could try and implement one of those changes and then grow it year on year.
Very good. Maria, thank you so much for joining us, and best of luck with the rest of your really significant campaign.
Oh, thank you.
Thank you for joining us. Thank you.
Thanks, Grania.
My name is Brian Bennett and I work with Let's Go Summer Camps. The camps are a multi-activity camp run in venues nationwide for children aged between 5 and 12 years. Our camps offer educational sessions mixed with the fun and games synonymous with summer camp. Maria and the team at the National Cancer Control Programme worked with Let's Go Summer Camps to develop a SunSmart lesson plan to be delivered at our camps and to provide every child with a UV protective top. In 2021, 9 camps piloted the programme. The aim of the programme was to teach children about the importance of protecting their skin, to teach them how to protect their skin from the sun, and to provide them with a sun protection resource. The camps went really well and we received very positive feedback from both our coaches and the children who attended the camps. We hope to roll out the programme to more locations in 2022.
My name is Bernie Rice, and my family and I lost Sharon, my daughter, to malignant melanoma skin cancer in February 2008. My family established the Melanoma Trust in memory of our daughter to bring about an awareness of this potentially fatal disease. I am on the implementation group for the National Skin Cancer Prevention Plan as a public representative. I have helped raise awareness of skin cancer as part of the annual SunSmart campaign. As part of the SunSmart campaign, the HSE's National Cancer Control Programme, in collaboration with Healthy Ireland and cross-sectoral partners, are working together to support people to protect their skin from the sun. The aim of the campaign is to increase awareness of the steps you and your family can take to protect your skin from the sun and reduce your risk of skin cancer in Ireland. Most people living in Ireland have fair skin, the type that burns easily and tans pearly. So we are at a high risk of UV damage and skin cancer. I urge people to protect themselves against sun damage, be SunSmart and follow the 5 S's. For more information on the ongoing work of the National Skin Cancer Prevention Plan and the SunSmart campaign, you can visit hse.ie/SunSmart.
A moving testimony there from Bernie Rice, whose daughter Sharon died of malignant melanoma skin cancer in 2008. Let's all commit to supporting Bernie in her work to make us all sun smart. Thank you to Marie McHenry at the National Cancer Control Programme, and a big well done to Brian Bennett at the Let's Go Summer Camps. And a particular thank you to Bernie Rice and her family remembering their daughter. The second project this afternoon is a programme which in many ways epitomises our theme today, citizen empowerment for optimising patient quality of life. Let's hear now from Living Well. The Sláintecare initiative Living Well, improving health outcomes for people with chronic disease by teaching self-management techniques via the Living Well programme, is our next project to showcase this afternoon. We featured Living Well very early on in the webinar series. In fact, I think it was the first or second webinar. The Living Well chronic disease self-management programme is delivered by trained facilitators to people with one or more long-term conditions. They include conditions such as asthma, COPD, diabetes, heart disease, stroke, and other chronic diseases. Given the challenges of our aging population and the increasing prevalence of chronic disease, this innovative model of care using the structured, evidence-based, peer-led format supports people to engage fully in true partnership in their own healthcare. To give us an update on how this initiative is going, I'm pleased to be rejoined by Maeve McKeown. Maeve is the Self-Management Support Coordinator in CHO Area 1. And in fact, many listeners will remember that the Living Well project is operating in 6 different locations: CHO Dublin North City and County, Southeast Community Healthcare, CHO 1, Community Healthcare West in partnership with Mayo Centre for Independent Living, Community Healthcare East, and Midlands Louth Meath CHO, and all 6 are being evaluated by Trinity College Dublin. Maeve, a long introduction. You're very welcome. Thank you so much for joining us this afternoon. Maeve, as I said, I know viewers will some will have heard about Living Well in the previous webinar, but would you just begin by reminding us briefly what Living Well is about, and maybe a little update on the progress since we last spoke with you?
Sure, yeah. So this project, as you say, is the Living Well programme, and it focuses on the establishment or the expansion of Living Well in the 6 CHO areas you've outlined, with Sláintecare integration funding. So project leads for these projects are the self-management support coordinators in the respective CHOs, and these were appointed as a priority action of the 2017 National Framework for Self-Management Support. And this framework is an essential element of the integrated model of care for the prevention and management of chronic disease. So one of its recommendations is the provision of generic structured self-management programmes targeted at those most likely to benefit. So Living Well is such a programme, and it is the internationally recognised Stanford University Model Chronic Disease Self-Management Programme. It's a structured, peer-led self-management programme for adults living with long-term or chronic health conditions, including those you outlined in the Integrated Care Programme of Chronic Disease, Diabetes, COPD, asthma and cardiovascular disease. And so the aim of Living Well is to enhance the capacity of the individual to manage the impact of their health condition on their life, and to thereby improve their health outcomes and their quality of life. So capacity building is enabled through the development of a toolbox of self-management skills, and this includes the core skills of action planning, problem solving, decision making, managing medications, communicating and collaborating with your healthcare professionals, managing difficult emotions, as well as promoting resource utilisation through the use of a resource table. And this signposts whole system supports such as social prescribing and exercise groups and community and voluntary agencies, etc.
And Maeve, tell me, in terms of the programme running across the 6 areas, but what are the patients who engage? I know people engage at different levels. Some of them are doing one set of activities, some doing another. So maybe tell us a little bit about what are people saying to you? Is it working for patients? What kind of activities are they getting involved in?
I think it's important to say, first of all, one of the key changes as a result of COVID was that the model of the programme delivery changed from one of in-person to online.
Yeah.
And so when that happened, it required, initially the in-person programme would allow up to 18 participants, and the online allows for up to 12 participants. But we're pleased to have seen that this model is proving successful. We've had 1,225 participants engaging since August 2020, over 120 programmes delivered online. So Living Well supports an individual with a chronic condition such as diabetes to develop the skills required to self-manage their condition effectively. So it will work with the individuals through the action planning process, where they can take small steps to make impactful changes on their health behaviours, for example. It supports people to work around the barriers that they might encounter on the way to improving their health behaviours, and supports them to find solutions to these barriers and challenges.
So they might end up with an action plan around, how do I increase my exercise?
Yeah.
How do I improve my diet? What are the small changes I could make to put me more in control, really, of managing a chronic condition, and thereby hopefully, make sure that I live longer and stay at home and basically away from acute services by managing my condition. You talk about, living well, supporting integrated care and chronic disease models of care. And I know you've done some research and you have some key learnings or results. Do you want to share some of those with us around the programme?
Yeah, so in terms of the key findings at this interim stage, and just to say that there is a collaborative research project underway we've engaged the services of an independent researcher at Trinity College Dublin, and we have interim results at this stage at participant level outcomes, and they're very positive. So key findings at this stage, for example, include significant increases in the individual's quality of life and their health-related quality of life.
Very good.
In their self-efficacy, which is the confidence to manage their health, in their digital confidence, including engaging in other e-health interventions, and in their perception of supports available to manage their health within the wider system, thanks to our resource table. We see significant reductions in levels of anxiety and depression, and levels at which illness interferes with their social interactions and social activities, including their work. We're seeing no change in the level of activity and exercise that people are undertaking. And this finding was examined in a bit more detail because it's in contrast really to findings more broadly and internationally indeed of previous studies into the Living Well programme. So we looked into the qualitative data around that, and this outlines, the reasoning or the possible reasons behind this, and they are COVID related, and the people are describing barriers such as the closure of their usual exercise facilities,
or just being nervous to go out maybe during the early Any other surprises in your interim results?
Well, yeah, we did have one of the last findings was the high levels of satisfaction, as I said, with the programme at 94%, and we've lots of qualitative data substantiating that. If you'd like, I can read through some of the testimonials on that.
Sure, that'd be lovely. Yeah.
Yeah, so in terms of, the different sort of reasons why people were satisfied, it was sometimes due that there was a peer support element and the sense of empowerment and control and other aspects that were valued. So we have our facilitators had a very respectful, caring approach. They brought their own life experiences and health issues to the table, which put us all in the same level and gave authenticity to their position. And another, I learned so much about myself and living with my illness. Previously, I would let my illness and symptoms consume me, and it would greatly affect my mental health. I never realised there was a different way of thinking and managing my life. It never crossed my mind before that I could have an impact on my own health.
Very powerful.
And we have a lot of really powerful testimonials coming through the research process. And surprising, I suppose, that to us, that level of satisfaction for the online version of the programme was a surprise to us. We know that it's anticipated with the in-person programme. We know, we've seen it, we have the evidence already, but really the pivot to online was a risk. There was a risk that it wasn't going to succeed, that people wouldn't get the same, I suppose, have the same experience or get the same benefits. So that has been a surprising and very welcome finding.
And will you keep that hybrid model, as it were, of online and face-to-face as we move hopefully out of COVID times? Is that the intention?
Well, that is one of the key learnings for the projects, that any future rollout must take account of participants' experience and desire, not only for the online, but also we have testimonials for people who the online wasn't, it's not a universal solution. Yeah. So we need to take cognizance of both those perspectives, and a future model we would hope allow for delivery of elements of both.
Very good. And I think we're hearing that from other projects who were forced to pivot in COVID, but actually the feedback surprisingly has been good, but one size does not fit all. So I think certainly giving choices to people is very important. So what's next for Living Well? Where are you going to go with it now?
The Sláintecare funding will finish at the end of December 2021. So the projects have collaborated to develop a business case, and that includes collaborating with the additional areas who didn't benefit from Sláintecare funding for Living Well. So we've worked up a business case for the upscaling and embedding of the programme to ensure it is continued and that it is more equitably accessible across all CHO areas. So the interim results have been really important in developing that case.
Very good.
It does remain to be seen how it would be worked up within service delivery, but it is hoped that there will be recognition of the value of the programme within an integrated model and that it can be mainstreamed within, you know, service delivery for chronic disease in an integrated way.
Very good, Maeve. That's great. Look, it sounds to me like you've all the right elements. You've piloted it, you've proved it, you've had to pivot even in COVID times, and certainly some of the testimonies that you read to us there, it's really making a difference for people with chronic disease. So well done to you, to the whole team of facilitators. I know there's a big team involved. Maeve, thanks so much for joining us this afternoon.
Thanks, Grania.
Maeve McKeown there, using citizen empowerment to improve the health and well-being of people with chronic conditions and keeping people well in their own communities for as long as possible. Thanks again, Maeve, and all the teams delivering the Living Well programmes across the various CHOs. Our third project this afternoon is about a new model of palliative care being tested, which spans both acute hospital and community palliative care. Rehabilitative palliative care optimises well-being and enables people to live as independently as possible despite advancing illness. It empowers people to adapt with dignity by providing a support system to help patients cope with changes associated with deteriorating health. Almost 5,000 people are seen by specialist palliative care teams every month, whether hospital-based or community-based. This number will increase by 27% by 2031. There is an urgent need to develop solutions to improve care. My guest this afternoon is Professor Karen Ryan, UCD clinical professor and consultant in palliative medicine. Professor Ryan, you're very welcome. You're involved in delivering this much needed initiative, rehabilitative palliative care, with Mater Misericordiae Hospital and St. Francis Hospice. You're most welcome, and I want to thank you for joining us this afternoon to tell us about your work. Would you begin, Professor Ryan, telling me about the project team and the model of care that you set out to develop in the project?
Yes, thank you. So I might just begin with explanation around palliative care. When many people think of palliative care, understandably, they think about care in the last days or weeks of life. And obviously that is a very important part of the care that we provide. But I think Dame Cicely Saunders, the founder of the modern hospice movement, said it very well when she said, "We will help you not only to die peacefully, but also to live until you die." And that really is the focus of modern palliative care. It's about optimizing quality of life. So we can provide care as the main focus of comfort and dignity, but increasingly we're becoming integrated with the chronic disease journey. So we can provide care alongside traditional interventional paradigms for those people with serious or advanced illness. So as our presence, I suppose, in the journey of those patients has grown, we really have listened to the voice of the patients. And while they say that things like pain control, symptom relief, psychosocial support are, of course, hugely important, very important things also are independence and functional ability, because that is so much of our identity, being able to continue as far as possible with the activities of daily living. And rehabilitative palliative care is very much that part of palliative care that tries to focus on improving function, occupation, and helping on all of those sides and aspects of personality. And as such, it's a little bit underdeveloped in our traditional model of care. And that's very much where this project came from. So our project team comprises Lisa Mannion, who's an occupational therapist based in the Mater Hospital, and Fiona Cahill, a physiotherapist based with our community palliative care services, to working with the hospital and community palliative care teams. And we also have two researchers, Fola Nichelaar and Bridget Johnston, to assist in the evaluation, because this is a novel or new service. And really where the project arose from was the idea that if we could incorporate a focus on rehabilitation and enablement in the hospital journey, spanning out into the community, reaching into people's homes, that we would help optimize people's quality of life in that regard.
Very good. So I think you're right. That explanation really does take us away from thinking this is all about the last few weeks before you die. Actually, working with these allied professionals who help people to continue to live, particularly at home and maybe independently, is core. Really interesting. Tell me a little bit more about the efforts to integrate these services across hospital and community settings. What are the challenges and indeed the benefits of this approach?
Yes, well, palliative care, always as a core part of its philosophy, has had this idea that we would try and provide services where the patient is. So our traditional palliative care services have a hospital-based consultation component, and then we have our community palliative care teams that reach into people's homes, and then we have the hospice that can provide day services, outpatient services, and obviously inpatient care as well. So we are used to working across those settings, but at the moment the integration of care is predominantly, I suppose, medically based. So my role, as you've mentioned, I have one foot in the hospice and I have one foot in the hospital, but we really need to develop the roles of our team members spanning those services as well. So in terms of the integration, as I've said, we have Lisa in the hospital and Fiona in the community. So one of the first steps really was developing that working relationship. So a core part of their work is in terms of phone calls, handovers, sharing of notes, moving to kind of similar documentation, using of outcome measures and so on. And then another important part, I suppose one of the benefits of COVID was the move towards technology. So again, with Fiona, she now zooms into our weekly MDT in the hospital, and she'll go through the patients that we have in the hospital, and she'll also then be able to provide some feedback on patients in the community that may be attending the hospital. So I suppose those were, some of the practical steps that we put in place. The challenges were, I think, finding the time to do that and recognizing the importance of that. And I would say that as the project went on, actually, we realized more and more that this time was essential time. It was really, really valuable time. Sharing the information, handing it over, it gave really an in-depth insight and understanding of the person and their place in their illness, and meant that there could be more of a seamless handover of information. And the patients actually recognized that, because in some of our evaluation quotes that would come back to us would be the piece around about, I felt that they knew who I was. I knew that my care had been discussed. So it was really interesting to us that there was a very concrete sense from the patients that they knew that there had been a handing and sharing of information, and that there was a sense of security that went with that.
Very good. And I suppose one of the other things, and you've mentioned it already, patient-centered, people talk a lot about patient-centered, but how did you actually make this a patient-centered approach?
Yes, I think really, firstly, with the conceptualization of the project. So we listened to what patients were saying to us, and they said to us that pain and symptom control were very important, communication, psychosocial support. But they really did say to us that the idea of being able to be as independent as possible, of not wanting to be a burden on their families. Now, families wouldn't necessarily use the same words in describing their loved ones as burdens, but I think all of us do have that worry or that concern that we're placing extra strain on other family members. So people would have said that to us. And I suppose so many of us also identify ourselves in terms of what we do in our lives. We're busy rushing from A to B, we're not always being. And it can be very hard for people to cope with the losses that go along with that changing identity. So in terms of the person-centered piece, I suppose the first piece was very much listening to that. So the next piece then was designing a service that was responsive to people's needs. So that would entail providing the care in the right place. So people in terms of hospitalization would say that rehabilitation is a part that perhaps sometimes is an add-on or a later part of the thought of the care plan. And to be honest, that is still a challenge that we see in our project. In terms of our hospital-based consultations, we're still seeing people in the final third of the journey, which is really useful information for us to have. And we didn't have that previously, but quite literally, if you're seeing people in the last days before they go home, you know, your ability to I suppose bend the trajectory of the hospital stay is diminished at that point. So the right place, and also for patients, that very much meant if I'm frail or less independent leaving hospital, I don't want to have to go out to appointments. Yeah. I find them tiring. I find them difficult. You know, the time that I have is precious, and the idea of being in traffic or waiting, all of those things. And also, I suppose, the additional concerns with COVID, the idea Indeed. Of, you know, entering public spaces. So the idea of reaching into people's houses became a very important piece. And then very much the individualization of the care plan. And I suppose this is the piece perhaps where the specialist case management approach is of benefit, because we would have had some patients where the focus was very much on improvement in functional ability, you know, measurable gains in, say, their independence, their walking ability, those pieces. For other patients, perhaps there wouldn't be quite as much potential for change in their functional ability, but there would be huge scope for helping them live with the level of ability that they have. So we call that enhancing mastery or self-efficacy as such. So if somebody is breathless because of advanced respiratory disease, we may not be able in some circumstances to improve their ability to walk distances, but we certainly can improve their sensation of breathlessness and the anxiety and fear that would go with that. And we can help people to pace and manage and adapt their lives so that they can cope better with that. So that would be a very much, I suppose, another part of the patient-centered piece. Then the final bit I would say is that patients would also say to us that their family unit, their carers, whether that be friends, family, significant others, are really important people for many people in the journey, and that they wanted those people involved and included. So that would be a core part of the service, that where desired, the carer would be part of the consultation, either for whole or for part, and carer education was actually a really big part of the services delivered as well.
Very good. So we can see then, you know, some of those benefits you're talking about, the improved self-efficacy, certainly reduced distress. I can see that coming through immediately. And the possibility of improved functional ability, obviously for those who can, again, really useful. And I think that involvement of the carers and family, so very much kind of a holistic approach. So where are you now with the project in terms of evaluation and this model, it seems to me, of very patient-focused palliative care? What are the next steps?
Yes, well, we're fortunate that we have the Sláintecare funding towards the end of the year. So that's allowed us to extend our period of evaluation, and our evaluation comprises a kind of a case study approach whereby we are interviewing staff members. We've already conducted the first set of interviews, but now with the additional period of time, we'll have greater learning from that. We're also interviewing patients and carers. Some patients are participating in a survey around about satisfaction with experience, information provision, and so on, and we're using that information. And we're also looking at some of the outcome measures, as you've mentioned, in terms of functional ability. So what we would hope is that on the basis of the findings that we have, the experience, now over 330 patients have engaged in the service, and the number is growing, that we'll be able to make submission in terms of service planning for continuation of the service. when we proposed the original project, I suppose we were quite pragmatic in terms of the timelines and the availability of staff. So we proposed a project that we thought was feasible within the resources that were readily available. But ideally, we should have an integrated pair of a physio and an OT in the hospital and a physio and an OT in the community. And so if it were possible, we would like to expand that project to have that fuller staffing to, I suppose, really move towards integrating the hospital-based rehabilitative component even earlier in the journey. And on the basis of that, conduct further evaluation. And I suppose in terms of demonstrating the effectiveness, we can then liaise with the National Clinical Programme, which has recognised that rehabilitative palliative care is underdeveloped and is looking for solutions. And if we were found to be successful on a regional basis with the enhanced service, that then would become perhaps the nationally replicable model of care.
Very good. That sounds like a great plan, and it sounds like you're well on your way to proving the evidence base for that. So well done on this. I'm sure the 300 plus patients that you've already dealt with have really benefited from it, and I wish you the very best. Thank you so much for joining us this afternoon, Professor Ryan. Thank you so much.
Thank you.
So an interesting project there of partners working together to provide improved access to allied health professionals for those with advancing illness. So you've heard about the work of these three initiatives, all funded by the Sláintecare integrated funds. I now have a panel drawn from the projects you've just heard about. So with me now, and don't forget, we are taking questions. If you want to put one in using the Q&A function, please do. So I'm delighted to welcome our panelists. We're joined by Maria McHenry of the Skin Cancer Prevention Programme, Maeve McKeown of Living Well, and Professor Karen Ryan with the Rehabilitative Palliative Care Project from whom you've just heard. So maybe staying with you, Professor Ryan, if I might. The Department of Health, I understand, is currently holding a consultation on the future of palliative care policy. How important do you think rehabilitative palliative care is to that consultation?
I think it's critically important. The current policy that we have dates back now to 2001. So the department is carrying out a consultation and very much invites and welcomes both public and professional opinion as to what were the strengths of previous policy that we need to hold on to, but also what are the new things that we need to consider going forward. And I would suggest, in line with what we've outlined within the video, that perhaps rehabilitative palliative care was something that hadn't been considered to quite the same degree as it currently is. And now that we've moved upstream in the patient journey, it really has become critically important. So in terms of policy, I would urge all people to follow the link on the department's website, and I'm sure it'll probably be tweeted out after the webinar as well. And there's a very straightforward survey that can be followed to gather people's opinions and really influence policy and services going forward.
Yeah, and in many ways, it's an opportunity to update this particular model into the overall model of palliative care. Would you talk a little bit more? You mentioned in the video, about people and their carers. Maybe talk a little bit about the nature and the importance of services to caregivers, whether family members or not, of your patients.
Absolutely. Well, palliative care really does have part of that philosophy that the care that we're providing is to the person, very importantly, but most individuals do live within a network of people, and we should also probably add in animals.
Yes.
That's important also. But, the people that you live with and surround yourself with are really important, and are important in supporting people in the journey that they are undertaking really as a result of illness. So we do know that informal caregiving absolutely plays a vital part in supporting our health and social care services, and there is a commitment in the carer strategy for a number of actions that would support caregivers, and parts of the support that we would see within the rehabilitative palliative care piece in particular are those pieces around about supporting function and enablement of the individual so that they can be as independent as possible, so that there are the physical benefits, I suppose, in terms of caregiving. Then there's the emotional security and confidence that goes with being able to care for somebody who is as independent as possible, but also that the carer themselves understands what are the limits, but the possibilities of what can be done with somebody living with a serious illness. And some of the testimonials and pieces that we would have had coming through in terms of the evaluation is that piece about striking the balance between wanting to enable somebody to do something as much as one can, but also being fearful and wrapping them up in cotton wool. So it is that piece within the programme about providing education and support to caregivers so that they can be partners in the management of their loved one's condition.
I think that's a real, I suppose, a concern on the one hand, wanting to wrap people up in cotton wool, and on the other hand, allowing people their own agency to continue perhaps to do what it is they can for themselves. A further question to yourself, and then I go to other panelists. What changes have you noticed in your services thanks to the integration of acute and community services?
I think we have noted a real impact on the quality of care that we were providing, and we are getting that feedback. So that's really important to us. I think the project has also shown us the possibilities of, or what can be achieved in terms of integrated working. As I mentioned, following the patient journey across the transitions of care has always been an important part of palliative care. But at the same time, when you really put focused effort, when you really make it a core part of your day-to-day business, when you build up the relationships and the networks across the services, it really adds an extra dimension in terms of the quality of interaction that one has with the individual, but the targeting, the selection of the appropriate treatments as such. Now, the pieces that we have also learned while we were aware that rehabilitative palliative care was underdeveloped and that we weren't providing it to the degree that we were, I probably wouldn't have recognized how late in the journey, people were getting physio and OT, but now we have that data, and we really need to bring that health and social care professional dimension to a viable model, particularly in the hospital setting.
Right, very good. Thank you so much for that. Could I come to Maria now, just back to skincare cancer prevention. Can you talk to us a little bit more about some of the outcomes of that Sun Smart campaign that we heard about in the video earlier on?
Yeah, sure, Gráinne. Yeah. So I suppose, as I mentioned earlier, the importance of sunscreen and midday sun were perceived as important, I suppose, when we compared the pre and post survey results. But I suppose when we delved a little bit deeper into that and looking, I suppose, at differences between men and women, I suppose sunscreen is important, we notice, between all men and women, whereas when it comes to midday sun, it's more significant among females. And then when we look at age breakdown as well, we noted that sunscreen is important for all age groups, particularly, I suppose, the 25 to 34 age group, and also the 65 to 74 age group. Whereas midday sun...
So when you say it's more significant, do you mean women take it more seriously?
Yes, so midday sun would be more important. So men would be less likely to, I suppose, go seek shade during the midday sun, whereas women would be more likely to. And I suppose learnings from these, we noted that I suppose we need to promote shade and clothing together with sunscreen, because I think people generally would use sunscreen as a protective measure, but maybe not shade and clothing. So there's definitely a need to raise awareness of that.
Very good. And I know from your own research and evaluation, you've had other findings when it comes to attitudes and behaviour in addition to what you've told us? Do you want to share some of those with us?
Yeah, sure. So I suppose there's been a number of research studies conducted here in Ireland, and they have all shown sunscreen is the most common protective factor. Men would be likely to wear a hat, whereas women would be more likely to go in the shade, wear sunglasses. And I suppose the same can be said for children. So there was a study done by the Institute of Public Health report on children's exposure to UV, and that also highlighted between girls and boys. Boys were more likely to wear a hat, whereas girls were more likely to wear sunscreen or clothing that covers their arms or their leg, and also to avoid peak UV hours. So I suppose for us, it's noted to us that I suppose we need to highlight clothing and shade as well as sunscreen are really, really important. And I suppose the data does suggest that different approaches would need to be made between younger children and as well as teens. So teens would have different approaches, and then males and females different as well. So there is definitely a need to highlight that among different genders and ages.
That's interesting. As parents, you know, having different strategies even for your kids is part of that. I know people, you know, just to maybe highlight, but you know, for anyone who has a concern either about a skin patch or something like that, go to the GP would probably be the first port of call.
Exactly. GP would be the first port of call. And then if there was a cause for concern, the GP can then refer them on to a specialist. So definitely we'd always recommend if there any changes or anything they're worried about, the GP would be the first person.
Yeah, exactly. Maeve, come to you. Thanks so much for staying with us. We've been talking throughout the series of webinars about how COVID-19 has caused various projects to pivot, has become our favorite phrase. How has we talked a little bit with you about the online pivot of the work, but how has your pivot affected the completion rates for your 6-week courses?
Well, we were surprised, pleasantly surprised to discover that completion rates have actually improved with our online program. So for a participant to be considered a completer, and again by the fidelity standards of the course of the program, they must have completed at least 4 of the 6 workshops. So the interim results we know indicate that completion rates for the online version of 92% compare very favorably with those reported internationally, averaging around 75%. So yeah, it's been a surprise finding and a very positive finding.
Very good. And when people complete the course, is there a follow-up? Because you know, you do a course and you're all fired up and you're doing all the right things, and 6 or 8 weeks later you're thinking, oh, I'm not doing that anymore. Is there some follow-up, hook them back in again?
There isn't strictly a follow-up built into the program design. And again, we are, I suppose, very much a strictly licensed program format. So, but what the program does aim to do before participants have completed the program, an objective is that they have engaged with some facility or some additional program within the community and voluntary sector, or you know, that they have come together as a group and that they're continuing to meet themselves. So it's a self-management program, and that's the ethos that is aimed for, really. But notwithstanding that, there's often commentary through the testimonials that people would absolutely love a follow-up. Now we do I suppose that it is possible for people to do the program a second time down the line, and after a couple of years, you know, there's no barrier to people doing that. But in general, we do aim to have people sort of independent, standing on their own 2 feet and following their own self-management journey on completion of Living Well.
Very good. And that self-management journey is really, it's a central and crucial part of the Living Well. And I know somebody recently who runs running classes, and they were saying, you know, the usual thing, week 1, there's a big gang of people. By week 6, it's sort of thinned out. But actually the ones who have most success are the ones who buddy up with someone, someone that they say, I'll see you at 9:30 at the park gates. And that gets them out of bed, it gets them to the park. So that idea of identifying those strategies as part of your program, what will keep me doing this kind of, if it's exercise or diet, finding your own strategies for managing that.
And we have had reports of people participants in the programme making fridge magnets of their toolbox, and they go when they go to the fridge, or when they're having any particular bad days or issues, they go to the toolbox and they say, right, what's going to help me here today?
Very good.
What
Very
tool
good.
can I choose from my kit today?
Yeah, yeah, and having the kit is fantastic. And I know we listed the CHO areas, and you talked about making a business case. Would you tell us about any plans for Living Well in the three? What would you need to get it running right up and down the country in the other three CHOs?
Oh yeah, so Sláintecare funding has enabled delivery in 6 of the CHOs, but as I said, yeah, the self-management support coordinators in all 9, we've all collaborated and we've worked towards a streamlined, consistent approach to processes and delivery. And indeed, when the pivot to online happened, it did enable participants from the other 3 CHO areas to actually join online, albeit there was a bit of a limit on the numbers that were, I suppose, enabled to do that. And again, since really the interim results particularly have come through, and the positivity of those results has enabled one other CHO area to commence delivery, and a second CHO area is working towards readiness to commence delivery. And the final CHO area at the moment isn't in a position to progress that, simply because there's no self-management support coordinator in post currently. And as you said, the business case has been collaboratively developed as well, and that case really uses the impact of the evidence to make a strong case towards making the programme available equitably across all 9 CHO areas to benefit people with long-term health conditions in all those areas. And that equitable access is important. And also, as I said, it's hoped there is recognition of the place Living Well can hold within integrated models of care for chronic disease and the value of it.
Very good. And I just see there a question coming in specifically for you, Maeve. Aoife, who is a home care nurse, asking where can they get more information about Living Well?
So really, I suppose the central point of contact for information, we do have a webpage, and you'll find all information about access and you know, who's it for, etc. on that page, which is hse.ie/Living Well.
Very good. That's great. Super. So in terms of, you know, our focus today is on citizen empowerment for optimizing patient quality of life. And I think each of your initiatives have really depicted our theme so well. I want to just take a moment maybe to look back at, you know, the dark days of the COVID pandemic. I know we're not out of it yet by any manner of means. But, you know, some people in previous programs have spoken about how the COVID pandemic was a barrier, but also a catalyst or an impetus even on the development of the work that they were involved in. Maria or Karen, would you like to comment on that? Was it a catalyst, a barrier? What's your sense? I'll come to you first, Karen, maybe.
In terms of the professional team working, actually, it was a catalyst insofar as it really made kind of Zoom virtual meetings, those, you know, a normal part of our working life. In terms of the patient engagement, it was a little bit more challenging because the particular service that we're focusing on here is the idea of, you know, reaching into people's homes because perhaps it's difficult for them to leave. So we did keep our community services rolling through COVID, although the rehabilitative palliative care component was suspended for a period due to the need for respiratory physio and so on. But we did pivot a little bit as well there, and did become a part of some of the classes and the breathing and the exercises and so on. So that has been very successful for some of our patient group, and then some others find it a little bit more challenging. So I would say that we will definitely hold on to the staff side of technology. There is a role for technology for some of our patient groups that we will also hold on to, but the in-person part is important. And then one additional piece that actually preceded COVID But I think there's been such a shift in all of our mindsets. It has really it is accelerating. Is the idea for us also that as a specialist service, we want to provide to support non-specialist colleagues in the provision of palliative care. So that may be community physios and OTs, and the idea of, again, educational sessions. So Project Echo would be a project whereby you create a community of practice-based learning, and using telehealth initiatives to support that. So those would be the aspects.
Very interesting. Yeah, great. Maria, COVID pivots?
Yeah, so I suppose for us with COVID, for us it was, I suppose, looking at all of the initiatives that were running. There was so much information out there for people. So knowing when to provide the information, people were being bombarded with information on COVID-19, vaccination. So especially for our SunSmart campaign, we had to kind of look and see when would be an appropriate time to release information and highlight information to people. I suppose luckily a lot of the work has been able to still continue on, even though with the COVID pandemic. So I suppose we had to move a lot of our projects that we were doing. We had a plan to do face-to-face, but we couldn't because of social distancing, so we had to move them online. And we had found really, really good engaging, I suppose, consultations with people online, which really helped us. I suppose also fighting COVID-19 has showed that behaviour change can happen. I suppose we all had to adopt to wash our hands, social distancing. So it has showed that, I suppose, behaviour change can happen, and it helped us kind of get learnings on how to engage with people, what works and what doesn't work when you're talking about public health initiative.
Yeah, and I think that point you make about, like, we all had to change the behaviors, you know, the massive washing of the hands, the masks, and many of us going back to those now, perhaps having let them slip in the last few weeks to try to keep each other and keep all of us safe. Maeve, I note from the colleague has just sent anything to say from your own website that there is actually some Living Well program starting in the next few weeks. So again, to encourage people who maybe have a professional interest or a personal interest to go onto your website, the address that you gave, and have a look and see if people can link in. We did speak during our video about some of the COVID pivoting. Is there anything else you want to add, Maeve, from your experience around COVID and either the barriers or the things you had to overcome?
Yeah, I think, again, the main decision happened back at the beginning of the pandemic when we were teetering whether we called a halt or we pivoted to the online, and that was the biggest change that we implemented. We also had to revise the content of in line with the licensing organisation and with their approval. We had to do an overhaul, a review of the content and revise it so that we made sure that for example, our resource table was digitalized. So it is normally an in-person program. It's a physical table with leaflets on it. We had to revise that to become a digital resource with and ensure that we had quality assured COVID resources signposted through the resource table as well. So the actual content of the manual that the peer leaders use for delivery had to be revised so that again, COVID was taken into account and current advice around COVID was taken into account as well, and appropriate signposting was engendered in it as well.
Very good. And again, there are people watching who maybe are also involved in trying to engage citizens, trying to empower people to optimize their own or their patients' quality of life. Is there one particular thing that you've learned from your project experience that you think, yeah, that's I learned that, whatever that might be, something you didn't know before you started, or for others perhaps who are embarking on a project development journey? Well, what piece of advice, is there some learning you'd like to share with us, each of you, about citizen empowerment for optimizing patient quality of life? What's the key to it? What have you learned? Karen, we'll come back to you there.
I think it is that piece about listening first, and there are a variety of ways that you can do that. I mean, we St. Francis Hospice has over 30 years of experience working in the community, and so we've built up very strong links and experience. But then there are partners and friends, like the All Ireland Institute of Hospice and Palliative Care has a citizens forum, patients, carers, advocates, right. and we did a session with them online actually early into the project as well, and we listened to their thoughts and feedback. And I think you know that you have the right idea when you can explain it simply, and when it resonates, and when the person says, yeah, that's it. So I think we get to that point.
Yeah,
we're kind of ready to really start the planning and going.
Yeah, and that of course is central to this idea of co-design. If you're listening to what people want and what they need, then you can meet those needs, and people really feel that their experience counts. And as you say, you know, people say, yeah, they talked about me, they know what my issues are. Maria, same question to you.
Yeah, so I suppose a lot of the work that I do as part of the Skin Cancer Prevention Plan is building collaborative relationships, working with a wide range of stakeholders. So for me, I suppose it's adapting to the type of audience you're speaking to, and I suppose learning from them on how to engage with them. And everything does take time. When I first started, we found outdoor workers organisations hard to reach. And since then, I suppose we've kept in contact regularly. We've listened to them, heard what they would like to see, what we can do to support them. And that's really, really helped us in the work that we're doing. So engaging regularly, building relationships, gaining trust is something that I found to be really, really helpful. And again, it does take time, but putting the time and effort in is really, really important.
Very good. And just before I go to Maeve for her final comments, in terms of your own work, Maria, what are the next steps for the National Skin Cancer Prevention Plan implementation?
Yeah, so I suppose there's work ongoing all the time with our Skin Cancer Prevention Plan. Now, our plan ends in 2022, the end of 2022. So I suppose the work ongoing from now is looking at a new plan, taking learnings, monitoring the changes and the effectiveness of the plan to date, and looking at what we can do going forward, because I suppose the plan is something, it's just starting off. It's the first of its kind here in Ireland. So there's going to be ongoing work. We know when we look at Australia, it took decades for them. They have a number of plans in place, and they have managed to reverse the rise in incidence, but it has taken a lot of time, and I suppose key learnings internationally as well as working with all the key stakeholders and getting, I suppose, input from them on what works, what doesn't work is huge for us. So lots of plans in place and planning for the new plan in 2022 plus.
Great, thanks, Maria. Maeve, back to you. The question about learnings, lessons. If you were to give people advice, what would you be saying to people?
Very important in the process at the very early stages is consultation with people who have experience of delivering the programme and who have walked the walk for longer than us, who've been in the space well before we came, the new kids on the block. And we have so much to learn. It's important not just to consult, but to listen, take on board and foster ongoing relations and partnerships with those organisations such as Arthritis Ireland and Irish Society of Crohn's Colitis, Irish Kidney Association, MS and Tala Hospital. So it's really important that we learn from them and not, not make mistakes that could have been avoidable through proper consultation and partnership. They've been very valuable along this journey for us.
Very good. So common thread there around really listening, hearing, and doing it as early, and maybe going back and redoing it as often as you can. Karen, Maria and Maeve, thank you so much for the work you're doing, for the time this afternoon to come on and tell us about these really important initiatives that you are involved in. I want to thank each of you sincerely. So many thanks to each of our guests here today, the panelists and those who featured in the videos. Well done to all the great Sláintecare project work as it continues. Today's emphasis on citizen empowerment for optimising patient quality of life, I think, is well depicted in the work of the 3 featured projects this afternoon, engaging people in their own preventative strategies for healthy living, supporting those with chronic illness to better cope with managing them, and enabling people to live better and longer by their own actions and supports. The level of inter and multi-team engagement that goes on, that goes into ensuring person-centered care and improves integration of care in the right place at the right time by the right team is, I think, the hallmark of many of these Sláintecare initiatives. I want to thank all of you, all of the team here who helped to produce the session, Rosaline Harlan, Muriel Farrell, Ciara Eustace, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch, and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, and do send us in your feedback. Thank you everyone for joining us this afternoon. The end of our 13th webinar has come. From me, Gráinne Healy, continue to stay safe, wash your hands and hold firm. Thanks everybody.